Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And today's presentation will be by Dr. Daniel Hofer, a family physician. He is Chief Medical Officer for the Outpatient Palliative Medicine for Sharp Healthcare. He's Medical Director for Sharp Hospice Care, and he is in San Diego. Dr. Hofer, I'm going to turn things over to you.
Thank you again, Larry. And today we're going to be talking about cognitive issues in the advanced elderly population, particularly delirium. The title comes from what you hear from family members when somebody goes into the hospital and they come out and the granddaughter or grandson asks, "What happened to grandma? You know, she went in for a pneumonia, she went in for a hip repair, and she's just not the same person." Delirium is the cognitive equivalent to frailty as the physiologic equivalent. And so this is about cognition, and I've already given the answer to the first question, but let's go ahead and get started. So I have no disclosures. This is a study looking at 425 consecutive hospital admissions. These are people aged 70 or older, and generally more frail because those are the type of patients that get admitted. 106 of these developed this particular problem. That's about 25%, very classic number. The one-year mortality for this demographic was 35%. Without the diagnosis, it was 21%. The two-year mortality was almost 60%. Institutionalization at 2 years was 54%, twice that of people without the diagnosis. And at 2 years, about 90% of patients with this diagnosis were either dead or institutionalized, 90%. The number of hospital bed days increased by a week if you had this particular diagnosis. And in a different study, the three-year mortality was about 80% if this event occurred. To put that into perspective, that is the same mortality rate as many advanced cancers or end-stage heart failure. Yet we almost never think of this diagnosis in the context of the mortality rate that we see with advanced inoperable cancers and heart failure. And what's the diagnosis? The diagnosis is delirium. Highly overlooked, highly misunderstood, and unfortunately, as pointed out in this quotation, is that abrupt declines in cognition and function in the elderly are highly associated with early death, and clinicians have underestimated this importance on the effect of brain dysfunction on quality of life and care for the advanced elderly. It should be considered a deadly diagnosis, and I encourage people to think of delirium in that context. Just to drive the point home, the one-year mortality for hospital-induced delirium at 30 to 40% is the same as a myocardial infarction in the advanced elderly or sepsis in the advanced elderly. And there's a mountain of things that we can do to prevent delirium or manage it better that we are probably not doing now. Because delirium can be iatrogenic, it's considered a clinical quality indicator from the National Quality Metric Clearinghouse of the HRQ. And they've determined the incidence of delirium to be a marker of quality of care and patient safety. So for those of you with HROs, or quality care councils in your hospitals, this is something that we need to be looking at more closely to be sure that we're doing the best to manage these patients, certainly with patient safety. The National Institutes of Health has recognized delirium to be the most common side effect of hospitalization for the elderly. A lot of people don't know that. They think it's infections or iatrogenic medication errors or some other side effect. It is hospital-induced delirium. The Institutes of Medicine considers early detection of dementia one of its 6 goals to improve quality of care in this century. And, you know, I'll show you the association between delirium and dementia because a lot of people are unaware of that association. The cost for delirium is profound. It's somewhere between $38 and $152 billion. That was from 2009. But think about that. The middle of that's about $90 billion. That's the same as diabetes. We have diabetic educators, we have endocrinologists, we have primary care physicians, we have nutritionists, we have diabetic physiologists. We have a mountain, an army of healthcare providers trying to improve care for diabetes, but what do we have for delirium? Nothing. We have us. And so we can improve this particular aspect of the advanced elderly, that neglected part of research and neglected part of healthcare, by looking at these patients more closely and more carefully. This is a recent study actually published last month. This is the one-year Medicare costs associated with delirium in older persons undergoing major elective surgeries, published in JAMA Surgery. This was typical number of patients developing delirium, 25%. 76.8 was the average age, very typical, and you can see the types of surgeries we're talking about. The increase in cost was $44,251 for that year. That broke down to index hospitalization, $28,000 for the readmission, and about $3,000 for post-acute rehab. Now that study was done from 2013 to about 2016. If you adjusted that to today's cost, it's $56,474 per patient for this diagnosis. And the annualized Medicare cost just for this particular research article would be about $33 billion. That's not talking about other admissions with the diagnosis of delirium. It's just this subset of patients. And here you can see the increased cost with delirium and the increased cost with severity of delirium on the right. Very expensive disease. So why do we have a problem recognizing delirium? Well, one of the issues is we call it by anything but its proper name. So we use acute brain failure, altered mental status, acute confusional state, toxic metabolic encephalopathy, confusional syndromes. There's all sorts of these things. The answer is we should be calling it what it is, which is delirium, and the various definitions and categorization of delirium. We'll talk about that. So why is all of this important as well? And it's important for frailty, or frankly any geriatric syndrome. And the reason it's important is that we recognize that about 75%, 90% of patients in the advanced elderly population would forego a treatment, even if the treatment burden was low, but the probability of severe functional or cognitive impairment was high. And that is always high when a patient has a geriatric syndrome. That compares to almost 100% of patients who would want the treatment if there was no significant risk of functional or cognitive damage. Those are the people that we historically researched. Everybody else we eliminated from research because they'd skew the results for the body of the patient population that we treat. And for the advanced elderly, they will tell us that mortality is not the major determinant of patient choice. They're, of course, want to live longer, but that's provided you can maintain their quality of life. And if you cannot, and that needs to be a clinical decision process, part of the process is looking at these geriatric syndromes, then maybe the patient wouldn't proceed if they'd been given full disclosure of the cognitive and functional issues related to their care. So to be up to date, we need to understand the physiology and the goals of care of the pre-terminal, the advanced elderly. The terminal populations are not the same as the younger and healthier geriatric patient. And each care standard needs to be individualized to the patient, understanding the organ system problem, the geriatric syndrome, and the patient-centered goals of care. So how common do we see delirium? Well, in hospice, we see it all the time. I worked in the ICU, very, very common. Nursing homes, 63% of the time. I spent 25 years there. You can see how common it is in hospitals. Certain surgeries, orthopedic surgeries, cardiovascular surgeries, particularly aortic procedures, it's common. Even 4% of cataract surgery, 25% of TAVRs, as you saw in the first presentation. In fact, when I started giving this presentation years ago, for the first 6 or so presentations, somebody would walk up to me after the presentation and say, that's exactly what happened to my dad or my mom after her cataract surgery. And I had one medical director call the ophthalmologist after hearing this presentation and say, I'm canceling the second procedure because if we see the effects of my father's delirium again, he'll never be back, even if his vision is perfect. So you can see the prevalence, you can see the incidence, and what you can know from all of this is it is a very common problem. It's underdiagnosed. So the old paradigm that acute hospital delirium is a medical emergency with significant short-term but not long-term consequences. You can't really tell who might develop delirium. Should have a big red X in that. And the new paradigm is that acute hospital or outpatient delirium needs emergent evaluation and is associated with both significant short-term and long-term consequences. We absolutely can predict who is likely to develop delirium. This is a prognostic model. It's the one I use. It's just my favorite one. I stick it in my pocket. Patients with dementia, poor vision, functional impairment, high comorbidities. Let's stop there. How many of you are taking care of people with cognitive impairment, visual impairment, functional impairment, high comorbidities? We all have them in our practice. If they also end up getting a restraint when they're in the hospital, they're at the highest level of high risk. Those patients have a 63% risk of developing hospital-induced delirium. And death or nursing home placement for those patients is 64%. The ICU is also a prognostic marker of a patient developing delirium. But I'm going to show you this slide for two reasons. Not only one, can you see that when a patient's 85, they have about a 75% chance of developing ICU-induced delirium. If they're 90 years, it's almost guaranteed. So as people get older, the risk of developing delirium, you're sending them to a procedure in the ICU is extremely high, and patients should be aware of that and the consequences of that geriatric syndrome in addition to fixing the organ system problem. But I want you to look at this slide in a different way. That flat area of the slide is where we did research. We deliberately excluded people over the age of 75, people with cognitive decline, functional decline, institutionalization, and multiple comorbidities, because those patients in the bar going up to the right would skew the results for the body of the patient population that we treat, that flat section of that graph. And there's nothing wrong with doing that. The problem is that we extrapolated results from that younger and healthier population back upon the line that's going up and said, hey, well, you know, I know we excluded you, but research is research, and this is how we are going to impose care upon that demographic. We did not realize these geriatric syndromes could markedly affect outcomes in a way that is predictable and manageable. What people should be aware of with delirium is, well, you know, you get delirium, it goes away. Well, that's the way I was trained. In fact, that's not true. 40% of the elderly who develop delirium never return to their previous cognitive function. Now, I borrowed that quote from Dr. Maldonado, who is a neuropsychiatrist up at Stanford, but that's the experience I've seen in reading the literature based on anything from 3 to 5 years. That was his definition of time frame. I'm going to show you some studies that might say it's an even longer effect or evidence for longer periods of time. This particular article was to test the hypothesis that hospitalization in the elderly is associated with subsequent cognitive decline. Now, we love using the hospital for the elderly, but in some cases, it may not be, in fact, the safest or the best place to treat these patients. This was about 2,000 patients followed for 12 years. They were evaluated every 3 years, and they followed their cognition doing a series of cognitive tests. They used global hospital cognitive decline standards, and this is a different model than the MMSE. And what they saw pre-hospitals, the rate of decline was 0.031 units per year. Post-hospital for the demographic age-matched controls, it went to 0.075 units per year. The overall decline in cognition, therefore, increased by 240%, the rate of decline. Memory decline memory decline increased by 330%, and executive function decline increased by 170%. And of course, it was worse if they were older in the hospital longer, had more severe illness. So the more severe the hospitalization, the longer the hospitalization, the worse the effect. And this is a graphic representation of that study over time. People who didn't use the hospital to manage their problems, people who did, cognition declined further, and the people who used the hospital were reactive in their care instead of proactive. We should be aware of patients with dementia are 500% more likely to develop hospital-induced delirium, so you can actually take a subset of the population and make their dementia worse. This occurs in about 2/3 to 90% of the demented population, so the absolute prevalence is very high. And we should be aware that the expense of a delirious patient in the hospital is very high. 49% of all hospital days for the advanced elderly is accounted for by the diagnosis of delirium. And this, in fact, is the representation of that accelerated decline for the subpopulation of demented patients. You go to the hospital, they already have decline, but we accelerate that when we put them in the hospital. There's several forms of delirium we should be aware of. This is how we should be labeling delirium. True hyperactive delirium is persistent hyperactivity, which is actually not that common. Usually it comes in the mixed form. Hypoactive delirium, however, is the most common form. Hyperactive delirium is that patient who's trying to crawl out of bed after their orthopedic surgery and they're agitated. The hypoactive patient is the patient after their surgery that's sitting there lethargic, is not communicating as well as they used to, and you just think they're medicated, but it's far beyond the point where that medication should have worn off. So if you stage the severity of outcomes with delirium, we start with no delirium. Subsyndromal simply means they don't have all of the characteristics of delirium. Incident means they developed after hospitalization. Prevalent means they developed it in the emergency room and came in with it. So you move up to incident delirium, prevalent delirium. And then the question, of course, is that just the precursor to dementia? So I used to work in the nursing home, and when patients came in with prevalent delirium compared to patients that did not have delirium, where do you diagnose the delirium? Well, you either saw that they had it or you read it in the nurse's notes from the hospital. And I could automatically tell these patients, and I'd have a different discussion with the patient and their families, that these patients were at higher risk of mortality, 500% increased risk at 6 months of dying if they had delirium. And it turns out as well that these delirious patients were the ones that end up permanently institutionalized. It's that third of skilled patients that stay in the institution. And subsyndromal delirium, even part of the symptoms of delirium, you can see has a hazards ratio of 3.4 over people with no delirium. This is the mortality rate for the general population. So it's not just the nursing home population, but if you take the advanced elderly, no delirium on top, delirium on the bottom, the mortality rate at 3 months is 80%. Extremely deadly diagnosis. And there's a subpopulation of patients that we are aware of today, and these are the COVID pneumonia patients. COVID pneumonia patients with delirium on the top, COVID pneumonia patients without delirium, the mortality rate is markedly higher if they develop hospital-induced delirium. One of the reasons we should be aggressive, more aggressive than we are today in managing delirium, because it doesn't matter whether it's COVID pneumonia or something else, these patients do not do as well, and we can aggressively manage these patients in a proactive manner. We'll be talking about the management of delirium in the next presentation. So if you look at the subsets of delirium, this is mortality over time, no delirium on the top, it's mixed and hyperactive delirium in the middle and hypoactive on the bottom. Hypoactive is a deadlier form of delirium. The longer the patient has delirium, the worse they will be. That's severity of delirium. And the less symptoms that resolve, the worse the patient does, the higher the mortality. So all of these prognosticate risk for morbidity and mortality for these patients. You can ask yourself, how often do I get a discharge summary, or am I making that diagnosis of, incident, hyperactive, persistent delirium over 5 days? Usually we get nothing, or we get patient had hospital confusion or altered mental status. The worst case scenario is prevalent hypoactive delirium, which persists with no resolution of symptoms. We have to remember this, that delirium is the intersection of the susceptibility of the patient and the severity of the insult. The problem isn't that we're not developing less severely insulting ways to treat our patients. It's that our patients are becoming markedly more susceptible to delirium. So even a single medication, let alone a minor procedure such as a cataract procedure or a TAVR, those can cause delirium. The medications can cause delirium. As our patients age, we must be aware of that. Otherwise, yes, we'll fix the organ system problem, but we will markedly deteriorate their cognition, maybe even to the point of dementia. What's the pathophysiology of delirium? Well, we all know about the hypoxia, the low blood sugars, the anesthesia. We're aware of that issue. I encourage people to remember the aberrant stress response, the inflammation. These are cytokine-mediated processes. You know, all the people listening to this have probably had a cold or a UTI, but you probably did not become delirious from that. When your brain is susceptible to delirium from a UTI, that is an incredibly poor prognostic marker. And to me, that's more concerning than a true allergy, because these patients do poorly with any intervention. Another infection, knife to skin for a surgery, they all induce inflammation that can accelerate their geriatric syndrome, and people should be aware of that. The only thing that's worse than the inflammatory aberrant stress response is the LHPA axis and the sickness behavior response. That's what we see when we move the patient from Northern California to Southern California to live next to their family, or from the ICU to the medical floor, or the medical floor to the nursing home. And patients get re-disoriented every time they're transferred, and they have a hard time reorienting, and they actually do very poorly. So we've talked a lot about delirium. We haven't gone over the diagnosis. This is the DSM-3R. This is the criteria. The acute onset, fluctuating in nature, inattention. Those are all necessary for the diagnosis of delirium. I wouldn't perseverate about fluctuation. It can be minutes, hours, days, weeks, any fluctuation over time, that counts as fluctuation. Disorganized thinking, altered level of consciousness, disorientation, memory impairment, perceptual disturbances. These patients can be agitated or psychomotor retarded, and that's why when they're sitting there lethargic in their bed, we tend to miss that. And they can have a sleep-wake disturbance problem. So all those patients who don't sleep well, in fact, we induce the 10th criteria in our hospitals by waking them up every 2 to 3 hours for a neuro check or a blood sugar or a blood pressure. In fact, one of the things to do to prevent delirium will be to alter that habit of interrupting our patients' sleep when they're in the hospital. So what's the difference with the DSM-3R criteria and the DSM-5? The DSM-5 states you need to look for a cause, and these changes in the patient's cognition can't be better explained by another cause. So for example, if a patient has anesthesia, we would expect that to cause altered cognition and psychomotor retardation and perceptual disturbance. I don't expect a UTI to do that. If the patient gets that, even though we're aware of that, that's called delirium. This is the confusion assessment model. This is a standardized tool that's been around for 31 years. In fact, it's an international tool. It has incredibly high sensitivity and specificity, both above 90%. This is a sudden onset and mental status change is necessary and needs to be fluctuating in nature. The patient needs to have inattention, difficulty focusing, keeping track of what is said, or easily distracted. And I'm going to give a pearl to primary care and outpatient physicians. If a patient's been hospitalized and they come back to your office and you used to be able to talk to them directly, and you find yourself having to redirect them to pay attention, or you turn to the family member to discuss what happened in the hospital because the patient can't stay focused, that patient has a high probability of having persistent hypoactive delirium, and you should be aware of that. Patients can have either 3 or 4, disorganized thinking, or altered level of consciousness, anything from being hypervigilant to being comatose. Here are some pearls about delirium. It's missed about 2/3 of the time. The range is from 50 to 85% of the time, just depends on the research article, but probably it's missed most likely because we're missing hypoactive delirium, just thinking the patient was given their medication or they're still recovering from the procedure. It's frequently misdiagnosed as depression, dementia, normal old age, and I'll give you some pearls about that at a later time. It's present at discharge in some studies as high as 1/3 to 60% of patients. So these are high-risk patients who go for high-risk procedures. You should expect to see delirium, and it should be on the discharge summary if it occurred. And be aware that the patient's MMSE will be lower if you do one on a delirious patient, which is why you cannot make the diagnosis of dementia of the patients in the hospital and they didn't have dementia before they came in. These patients' MMSE can drop precipitously and be for a prolonged period of time. So the biggest issue for delirium then is not about treating it once it occurs, the reactive model of healthcare, but to proactively prevent delirium as the most effective strategy to reduce its frequency and complications. Once present, the management of delirium has not been shown to improve long-term mortality or institutionalization. So the bottom line to that is there's no return. Delirium occurs. If you didn't do everything you could to prevent that, there's some ownership in the fact that the patient now has a disease that was given to them by their hospitalization or surgery or procedure that we should have been doing everything we could to prevent, and the patient and family should have been forewarned if they were at risk. What are the most common causes? Medications, infections, metabolic abnormalities. I remind people that we've been encouraged not to do laboratories prior to younger and healthier patients for surgeries. That is not the case for the elderly population, particularly advanced elderly. All metabolic abnormalities should be fixed if possible. Now, this is an older study, and the reason I kept it in is because things haven't really changed, except for maybe the heart failure issue. It's still a cause of delirium, but I think people need to realize that the medications, infections, and metabolic abnormalities are the most common causes. Delirium to some extent is iatrogenic. These patients become dehydrated. We need to be sure they stay hydrated. We need to mobilize these patients as early as they can be mobilized. There is nothing good about keeping a patient immobilized. Do not use chemical or physical restraints. Psychoactive medications, including things we don't think of as psychoactive, such as antiemetics or some hypertensive medications, those can be psychoactive. Catheters, I think we're good at dealing with. Metabolic derangements, if you are not checking laboratories prior to surgery and fixing the problem, that's something we should be concerned about. Nutrition should be improved prior to hospitalization or surgery. Sleep deprivation we actually induce, as I already discussed, that needs to be fixed. And complications of diagnostic and therapeutic procedures which may not have been necessary. So once I developed my home-based community palliative medicine program and taught my families about delirium, the number of families that called me saying, I think my mother's having a TIA, changed precipitously. If they weren't having a fever, if they weren't having a focal neurologic deficit, they would call and say, well, what do you think we should do? And the question, of course, is, would you want to go through all of the therapeutic interventions if this was a TIA, or should we just put them on an aspirin or double their dose? And in fact, that would keep them from accelerating their geriatric syndrome by sending them to the hospital and performing interventions and therapeutic procedures that could accelerate their cognitive decline. So I'm going to remind people that delirium is directly related to the number of medicines prescribed. You'll see that in the next presentation, and the number of drug-drug interactions. That's why it's important to de-intensify medications as people get older. They're more susceptible to those drug-drug interactions, even if they've been on those meds for decades. And anticholinergic medicines are far and away the most concerning medications that we prescribe our patients, and we tend not to think about. So polypharmacy, to me, of the elderly is an iatrogenic disease, and it's something we need to do better with. Polypharmacy relates directly to the incidence of delirium. So what's going on with the geriatric patient that makes them so susceptible to this problem? Well, part of the issue is that they lose hepatic blood flow. They lose about 40% of the blood flow to their liver. Their kidneys aren't clearing medications as well, so you have two reasons for increased blood concentrations, even if they've been on the same medication for decades. There's decreased protein binding. That's a third reason you have more free medication. You have altered body composition, so that can change the amount of free medication depending on whether it's lipophilic or hydrophilic medication. And there's increased cognitive sensitivity. So what's that mean? That means their blood-brain barriers are letting things through into the brain at a lot easier rate than they did when they were younger and healthier. And there is a loss of neurons, particularly cholinergic neurons. So that same Tylenol PM you took when you were wanted to sleep before your presentation or before your test you were taking when you're young, can have deadly consequences to these patients when they're older. And they also have increased physiologic sensitivity across multiple physiologic systems. So I always remind people, beware. If you get the phrase normal brain for age, it's the brain for age statement that you should be concerned about. This person has an older brain that has consequences, and be sure you understand what that means in translating care to your patients. So delirium has been associated with all of these complications, medical complications, ICU use, longer lengths of stay in the hospital or skilled facility. Again, in the skilled facilities, patients tend to become custodial, higher rates of permanent institutionalization, readmissions cost, mortality, and permanent functional and permanent cognitive decline. So let's talk about that a little bit. This is a study published in 1994, Progression and Resolution of Delirium in Elderly Patients Hospitalized for Acute Care. And the question was, does delirium go away? It's called the Harvard Delirium Project. 325 patients, about 31% developed delirium. 96% of these high-risk patients developed delirium symptoms, so that would be subsyndromal delirium, and they had symptoms of delirium at discharge. Only 20.8 of the 31% and 17.7 of the 96% showed complete resolution of delirium symptoms at 3 and 6 months. This was a study done in 2003. Standardized face-to-face evaluations. This was medical inpatients that developed delirium, 1, 2, 6, and 12 months. 135 patients, 34 developed prevalent delirium, 91 had incident delirium. And what did they see over the course of 1 year? At the end of 1 year, in demented patients, they'd lost only one of about 4.5 symptoms. They lost a little bit more than one if they did not have dementia, but again, at 12 months, the symptoms didn't go away completely. And this, in fact, is what that looked like. Demented patients on the top, cross-hatched, and just the crossbars are non-demented patients. You can see it gets better at about 2 to 6 months. And since it's fluctuating, we catch them at the nadir of one of those fluctuations, and we think they're back to normal. In fact, it's slow and insidious, and the symptoms of the delirium start to come back. And this is if you break it down into the symptoms of delirium, you can see that the inattention, disorganized thinking, disorientation, those are the worst of the symptoms. The top line is executive function, so you can see why sending these patients home, it doesn't matter what you do, they're not going to be able to follow your instructions. If you have not identified these patients as a subpopulation of patients you're discharging, they're the ones that are going to be back in your hospital. And then there's the memory impairment, which challenges us whether this is actually the precursor to dementia. This was a more recent study. We keep coming more up to date. This was a postoperative delirium and poor cognitive outcomes with dementia. These patients had no pre-existing cognitive, hearing, or visual deficit. These were known hip or knee replacements, mostly fractures. 25% were elective repairs. This was a 5-year prospective study. So what did they find in the patients that developed delirium? If you developed delirium in the next 5 years, you were 10.5 times more likely to be diagnosed with dementia. This was a meta-analysis published in JAMA in 2010, so even more recent date. They looked at research articles similar to the last one I showed you, and what they found is that when a patient develops hospital-induced delirium, they are 12.52 times greater risk of developing a diagnosis of dementia in a 4.1-year window. Now think about that. Your patient had delirium 3 years ago, and you diagnose them with dementia today. Are we looking back and recognizing that that diagnosis of dementia today came directly from that hospitalization for which they had hospital-induced delirium that we probably missed? There is a great opportunity to improve outcomes for the cognition of our patients and preventing dementia by recognizing this association. These were some of the original research articles showing the permanent association between delirium and cognitive decline. Subsequent to this particular review article, there are now dozens, if not hundreds, maybe thousands of research articles showing the same association. I'll leave you with this one last article. This was high risk of cognitive and functional decline after postoperative delirium. So I'm adding in functional decline to this research article, but I could have given this whole presentation based on function and not just on cognition. This was a 3-year prospective study, pre-op and post-op evaluations at 8 and 38 months. These are people aged 60 years of age and older. That's me, or I'm right there. I'm right under 60. Excluded a pre-existing dementia or pre-op delirium. 200 patients, once again, 20%, very typical number, developed delirium. Most of these are women, but I want you to see that most of these were also elective procedures, which is why for every single patient we should be doing cognitive and frailty evaluations. The National Surgical Quality Improvement Program says at age 70, but maybe we should be doing it earlier. What did we find in the patients that developed delirium? That at 3 years and 2 months, about 33 had died, but if you had delirium, you were 36% more likely to be dead. Every single time you see delirium and mortality statistics, it will be somewhere between about 200 and 500% increased risk of mortality. At 38 months, more than half of these patients, 5 times as many, had severe functional impairment. And as far as cognition, more than half of these patients had severe cognitive impairment, 14 times greater risk. If you forget everything else I said about this presentation, this is the slide you need to remember. And when you have a patient who's at risk of delirium, you should be doing everything you can to prevent that patient from developing delirium. And that's what the next presentation is about. And we should also be forewarning the patients and their families so they can make decisions based on inevitable consequences of well-intended care. So that's the data. Data doesn't lie. This is the consequences of delirium. It's a very important diagnosis. It's highly prognostic of future risk, and it's something we need to become more aware of. So with that, I say thank you very much, and I hope this helps you with your clinical practice.